So hi, everyone. Thank you for joining us. We're going to go ahead and get started. And as a reminder, this will be recorded. So you can also check back. The recording will post on our site in the near future. But welcome to everyone who's joining us this evening for the next installment of our AUA Newsworthy webinar series. This one is called The Breaking Research from the Atlas Study Group, Non-Muscle Invasive Bladder Cancer News. I am really pleased to introduce Tom Halsey and Dr. Sandeep Prasad as our conversationalists this evening. I am very excited about Mr. Halsey. He's our first ever brand new AUA News Patient Perspectives Associate Editor. This is a big deal for the AUA News platform, and he's already been a tremendous addition to our AUA News team. And Dr. Prasad is a world-famous bladder cancer expert, one of our favorite Journal of Urology authors, and tonight we will focus on his findings and his co-authors' findings in the Atlas Group publication that published in the Journal of Urology in this past year. So I am going to pass the mic over to Tom Halsey and ask him to introduce himself. Also ask Dr. Prasad to introduce himself, and then we'll get started with our great conversation. I will remind the audience that this is meant to be an interactive session. So please put your questions in the chat. You're also welcome to raise your hand using the raise hand feature here on Zoom if you have any questions or would like to raise a discussion point. So with that, Tom, to you, please.
Well, thank you for the kind introduction, Jennifer. I'm Tom Halsey, and I live in Dallas, Texas. And I heard the words you never want to hear from your urologist on my birthday in 2015. And that is, I was diagnosed with prostate cancer. And I was a typical guy. I was embarrassed and I was ashamed. And I kept it all inside. There's many lessons learned in my journey. But one of the things that compounded my angst was the fact I had just witnessed my best friend lose his life to prostate cancer. And it was absolutely gut-wrenching. And I didn't want to go through what he went through. But since then, I have, since my treatment and all, I have it's really become my life's passion to be an advocate for cancer patients, and AUA has given me the platform, and I'm so honored to be here.
Well, Tom, I got to tell you, this is our first time meeting is on Zoom this evening, but I think this type of endeavor by the AUA to really have patients drive the discussion about what we're doing in urology, I think is terrific. I'm really excited to talk with you tonight, as I don't know any of the questions that you may ask me, but I'm happy to talk to you on behalf of the Atlas investigators. I think the study here was selected because it's really quite an innovative, unique approach to treating a cancer that many of us take care of, which is bladder cancer. So, I'd like you to just lead off with questions. I want to thank the AUA on behalf of the Atlas team. And I really do encourage the audience to jump in with questions via the chat format, raise your hand. We really want this to be an interactive session between the urologist, myself, study team, and the audience, as well as Tom really leading the discussion and driving it for us.
Well, thank you, Dr. Prasad, and it's really nice to meet you face-to-face this evening. And it's really my honor to lead this interactive roundtable webinar that highlights one of the latest bladder cancer treatment trends in the future of bladder cancer in urology. Low-grade, intermediate-risk non-muscle invasive bladder cancer accounts for approximately 50% of all bladder cancers in the U.S. The risk of disease progression is low, but the recurrence is high. TRBT is the current standard of care, and improved methods aimed at optimizing disease clearance and recurrence to avoid risk of repetitive surgery and anesthesia are vital. We're going to discuss the recently published findings of the Atlas Group in the Journal of Urology and with Dr. Prasad's insights. Dr. Prasad was the lead investigator for this randomized controlled phase 3 trial, the Atlas study. And as Dr. Prasad and Jennifer said, we encourage your questions, and it's highly interactive here. But I'd like to start with the first question to Dr. Prasad, though, is what is this study and why is it so important?
Yeah, I think let's talk about bladder cancer, because I think you gave a really nice introduction about this very common cancer, right? So there's about 800,000 individuals in the United States who suffer from bladder cancer. Some of those patients have high-grade disease. They often progress and unfortunately die from their disease. But there's a preponderance of patients who have low-grade disease. Now, that's actually the majority of these 800,000 patients who suffer from bladder cancer. They're the patients that, as urologists, we'll see time and time again in our offices for evaluation of bladder tumor recurrence. And so the low-grade patient population, why it doesn't carry a risk for metastasis and death, it commonly recurs. And so it's really an important part of the urologic oncology practice and really the practice of all urologists across the board. And there's a subset, you kind of alluded to this, Tom, of low-grade cancers that are more troublesome. And they're grouped together in a category called intermediate risk, low-grade non-muscle invasive bladder cancer. These are tumors that are more likely to recur, and therefore, for patients, require them to have more procedures and possibly more side effects from our treatments. So this group, that intermediate risk, low-grade non-muscle invasive cohort, that's the study population. So who are these patients? These are patients all who have low-grade disease, but some of these tumors are large, so greater than 3 centimeters. Tumors can be multiple in the bladder. So when we look inside, it's not just one spot, but there's 2, 3, 4, or 5 tumors in the bladder. And then there's those tumors that keep recurring. So tumors that have recurred within the past 12 months are also grouped into this population of intermediate risk, low-grade non-muscle invasive bladder cancer. And again, that's the focus of this study. And I think it's a really important focus for urologists. So again, large tumors, multifocal tumors, and tumors that recur. Remember, patients, they're generally male, they're in their 70s. The biggest risk factor here is smoking, right? So these are either many are ex or current smokers. So a lot of these patients have existing cardiopulmonary disease. These are often pretty sick people. So when you're talking about taking them to the operating room to remove a tumor, as you mentioned, we want to try to avoid that. These are patients who anesthesia is not good for them. They're older, and again, they have issues with their heart and lungs. Many of these patients are on blood thinners. We have to stop those blood thinners, putting them at risk for heart attacks or strokes. And again, every time this patient recurs, they're at risk for going back to the operating room and requiring another procedure. So again, I think the need for this type of study is really important to minimize or even eliminate those trips from the operating room. So you kind of asked about what the study looked at. So it's this really unique way of thinking about treating tumors of the bladder. So historically, we've always gone in and resected tumors out with a camera, right, called endoscopic resection, or something we call TURBT. Every bladder cancer patient knows that terminology because they're so familiar with that terminology, whether it's waking up with irritation in the urinary system where it burns or stings. Sometimes they have to have catheters for a few days. They often see blood in the urine. And so the idea of trying to approach this non-surgically has always been of interest to us. And really, it's interesting. There was a product developed in the urinary lining of the upper portion of the urinary tract, which is actually the first approved product by the same company that created the study drug here. The drug in the upper tract is called UGN-101. The study drug here is called UGN-102, so it's kind of the second iteration. But UGN-101 is now actually FDA approved. It's a product called Jelmyto, and that was used to actually try to place a gel with mitomycin, which is a chemotherapy we all have used in urology for many decades, putting that gel on top of a tumor and seeing if it can melt away. And in the studies in the upper lining of the urinary system, it looks like about 55 to 70% of the time, just by putting the gel on top of the tumor, you can make it dissolve away. And that is really sort of a completely new way of thinking about cancer treatment, where historically we've used radiation, or we've had to give patients surgery or chemotherapy. The idea here now is something called chemoablation. It's a non-surgical approach. It's using some sort of topical product. And so the study drug here in this study is sort of the second iteration of what's been approved in the upper urinary lining, now studying it in the lower urinary lining. And this is UGN-102. That's the study drug. So how does this work, or why is it different? So the drug that works is a drug called mitomycin. So we've used mitomycin in the bladder for many, many years to wash the bladder after we do a TURBT. And so we know that when we wash the bladder with this type of chemotherapy after we try to resect the whole tumor, it actually minimizes the chance of it coming back. So urologists have been familiar with this drug for a long time. The problem is it takes a long time to make contact with this drug before it actually begins to do this chemoablation. So that's the trick. You can't hold it for long enough, right? You eventually have to pee it out. And so the drug is unique in that it has this product called a reverse thermal hydrogel. And that's really kind of the magic of UGN-102. It's basically that mitomycin, the drug that we all know and use in bladder cancer, is now put into this gel that coats the lining of the urinary system and maintains contact for 6 to 8 hours. So no matter what, if you've peed 2 times, 3 times, 5 times, the gel still sticks to the wall, allowing for that contact time. And it appears that that contact time or dwell time is actually what caused these tumors to then begin to chemoablate. And so that's kind of a really unique thing. So it's been proven in the upper tract and FDA approved. The second iteration of the drug is to see if it works in the lower urinary tract. And again, that's what Atlas studied.
From a patient perspective, the one word that you used was non-invasive, and that's obviously very, very attractive from a patient perspective. And you, Dr. Prasad, you've answered this pretty much in your earlier, but what would you say are the main findings of this study?
Yeah, so the study, it's a prospective randomized phase 3 study of this gel, again, in this population, that kind of notorious low-grade but intermediate risk population, the ones that keep coming back on us, right? So again, this is a pre-selected group of patients that are at higher risk for recurrence. That's what makes them intermediate risk, and that's what makes them so interesting to study and try to avoid going to the operating room. So in the study, in Atlas, about 282 patients were randomized to either having a lesion identified and then cut out. So that's the control arm, that's TURBT. Or in the other half of patients, the lesion was identified, confirmed to be low grade, and then left in place, and then the gel was administered. The way we often do studies in bladder cancer or urothelial cancers is we model drugs on the same way in which BCG is given. So BCG is one of our landmark products that we use in bladder cancer to wash the lining of the bladder and to provide the ability to minimize disease recurrence and progression. And the way BCG is given is you give it once a week for 6 weeks. So many studies that are designed in bladder cancer model off of the BCG schedule. And so patients who get UGN-102, they get it via a catheter that's placed in the urethra. There's no anesthesia for that. And the gel is administered via this catheter, and then the catheter comes out. So again, that's a 1 minute to 90-second procedure that can be done in the office to administer the gel via the bladder, and then the catheter is removed. So patients were randomized 1-to-1 in that. When patients finished their treatments, either they had a resection or they didn't, and then they just had the gel, we then looked back into the bladder 3 months later. And that's kind of the model we typically do when we do bladder cancers. We look about every 3 months or so to check to see if things have worked or have come back. And so that was the primary endpoint of the study, was to look in with what's called a cystoscopy, that visual check of the bladder. We also look under the microscope for cancer cells, that's called a cytology. And those both had to be negative. And that was, if they were negative, that was considered to be a complete response at 3 months. And the two groups had very similar complete response rates. So for patients who had a resection, but remember, a resection of this higher risk group, about 64% of patients, when we look back in 3 months later, they were disease-free. But again, about a third of patients had disease that we saw again in the bladder, despite the fact that 3 months earlier, an expert surgeon had gone and removed the entirety of the tumor. For patients that had received the gel only, no resection, the complete response was actually just a tiny bit higher numerically, 65% compared to 64%, but fundamentally the same. So for the majority of patients, almost 2/3 of patients who had no TURBT, simply by placing the gel into the bladder sequentially over a period of weeks, the tumor went away. And again, that's sort of an amazing finding, right? That by just putting a gel on top of a tumor, you can make it go away. That's very different than the way we use mitomycin historically. Historically, we had to remove the whole tumor with a TURBT, and then we'd wash afterwards. That's called adjuvant therapy. That's to try to prevent disease from coming back. You're kind of washing it to take care of the cells that may be floating around or whatever. This is primary therapy. This is actually competing with TURBT. This is, instead of TURBT, you're seeing essentially the same numerical complete response rate by never doing a resection, by simply just washing the bladder. So again, those patients didn't have to hold their blood thinners. They didn't have to have a surgical procedure. They didn't have to go under anesthesia. And very importantly, when we follow these patients out in Atlas up to 15 months, we saw that there was a higher probability of being disease-free and what we call a more durable response, meaning you maintained that complete response for longer, whether patients were disease-free at 3 months, you did better long-term. But even if you were in that 1/3 of patients where it came back in both groups, then we still followed those patients anyway. That patient got a tumor resected, TURBT was done. We said they weren't a complete responder, but then we followed them anyway. Those patients that got the gel first and then had a resection did better as we followed those patients out. That idea is sort of like a neoadjuvant, like a combination treatment with the study drug and TURBT. Those patients had a more durable response long-term compared to patients who just had a TURBT alone. So there seems to be an advantage for primary treatment where you respond at 3 months and we follow you out anyway and you do better, or in a neoadjuvant statement where, yeah, you didn't get it all, didn't ablate it all away, but you still seem to get a durable benefit long-term. And to me, this kind of makes sense, right? When we go in and do a TURBT, we're trying to look and find the tumors with our eyes. We typically use something called white light. That's sort of the regular, you look through a camera and you see the tumors. We have some other tools, narrowband imaging, CysView with blue light. There's some technologies that can help us see these tumors better, but fundamentally we're relying upon our eyes to visualize the tumor, and we cut out what looks visually abnormal. And the reality is those novel visual therapies, the narrowband imaging, the CysView and blue light, they show us that when we do more to try to find tumor, more technology, we actually find more tumor. We're not perfect at doing this with our eyes. And so the truth is that some of these patients that are recurring, maybe they've got tumors that are just so small we can't tell yet. And then we just miss them on the first go around, or they're tucked into a part of the bladder we don't see that well. But the gel's different. The gel's basically agnostic to what you see, right? It goes everywhere. It coats the entire surface of the urinary lining. So if a tumor is visible, great, it's going to cover that one. And if there's a tiny microscopic tumor that's just too small for us to see yet, it's actually treating that one as well. And I think that's where that durability of response may come from, because we see that benefit kind of with any initial response, is we see a benefit long-term. And I think that makes sense, that those microscopic or tiny recurrences that we missed the first time that pop up 3 months or 6 months or 12 months later actually are getting treated the first time. You don't have to really see them to treat them. And so it makes sense to me that the gel potentially gives you a better long-term response. And it's really, I think, outstanding that it gives you basically an equivalent short-term response to TURBT. There's obviously side effects to all treatments. In the study, we asked patients every time we saw them if they were having side effects. So again, patients who had the study drug administered once a week for 6 weeks, we asked them more times if they were having burning or they had blood in the urine or frequency and urgency than someone who had the resection, then we only saw them 3 months later. So we did have more adverse events reported in the study group, such as the burning, the frequency, the urgency, than we did in the TURBT group. But we look at a very important category called treatment-related serious adverse events. These are the major side effects that we think are important to know about and to counsel patients about a drug. And none were seen in the study group, in the 100+ patients that were in that study arm. So again, I think you're seeing an effective treatment for complete response. You're seeing a durable treatment in terms of long-term response, and you're seeing a safety profile that I think is really favorable. So again, we were extremely excited to see these final study results, and obviously have the opportunity to present them to the urologic community. So.
Of the of the 282 people that were in the study group, were most of them over 70, as you alluded to earlier?
Correct. Yeah. So the majority of patients were over the age of 70. About 2/3 were male. So again, that kind of reflects the general population of bladder cancer, and the clinical trial again reflected the typical population of these patients. I'll talk to you about some of the deeper characteristics about, we talked about those 3 categories: big tumors, multifocal tumors, recurrent tumors. They're going to be important when we talk about one of the limitations of the study, which, I think is really important to talk about in these types of fora. And that limitation is in regards to the use of chemotherapy right after a resection. And that's kind of something that, as this paper has been published, we've seen some editorial comments that talk about this. And I think it's really important. It's an important part of the conversation. But knowing the type of patients that were in this study, like you just asked about, is a really important part of understanding how do you compare this study to maybe another study, and how do you compare the findings of another study? Should that be applied necessarily to this study? So, but I think this patient population, which is described in detail in the paper, really reflects the typical bladder cancer population that we see.
So I would think, with this clinical trial that people of this age group probably have the pre-existing conditions, but this is one of the advantages to the study, if I understand correctly.
Yeah, so you're right. So again, we talk about older patients, and again, realize the number one risk factor for bladder cancer is smoking, right? So many of these patients were former smokers. Some of them are still current smokers, and obviously we work on that. But for those former smokers, unfortunately, they also pay the price for their lung function. So anesthesia is a big deal. For their heart function, they're on blood thinners because they've got a stent, right? Sometimes kidney function. And so these patients, they're frail compared to many cancer patients who are younger age. So
Yep.
I would say in my experience, my prostate cancer patients are generally much healthier and much younger. These patients typically are older and in less good condition. And remember, unlike someone who has prostate cancer who might have a prostate cancer operation, these patients may have multiple operations in the course of a year if they keep recurring, right? So like you said, the population is really important to understand where the value is for a potential non-surgical option for a disease that basically we manage surgically all the time.
Are there any, I know you've already talked about limitations. Are there any others that you care to share?
Yeah, no, I think it's really important. Every time we talk about a study, I think we have to talk about the limitations. These are in the paper, and I do want to spend some time talking about them. We've had a lot of interest in the study, which is great. Some of those have been in editorial responses. The Journal of Urology was actually had a dedicated editorial response to the Atlas study, which I thought was a very good response. And I think in a few weeks, we'll actually be doing a bit of a roundtable again, Tom, with some of the authors of those letters to the editors, as well as those editorial comments. But I do want to raise them because I think they're really important. And I think there's something that we have to think about in the context of the study. So the first thing is this study was actually stopped early. So the design of the study was actually enroll, I think, 700 something patients, and we stopped at about 280. And why did that happen? So the sponsor actually elected to pursue what's called an alternative development strategy. I'm going to talk to you about that in a second. Because during the course of the study, remember, this is a randomized study between surgery and a non-surgical option. They identified an opportunity for gaining potential FDA approval and registration to actually open a single-arm phase 3 study called Envision. I'm going to talk to you about that. I was the principal investigator on that study as well. There is some publicly available data on the 3 months for that study. But because this study was stopped early, the study is actually underpowered. We didn't have enough patients to actually show superiority. And unfortunately, that is a limitation of the study. So we're really doing sort of numerical comparisons here because we didn't get to do sort of the full accrual of the cohort. But again, that was an intentional design by the study sponsor to put their resources into a single-arm phase 3 study called Envision. So Envision used the same drug, UGN-102, but it looked specifically at those patients that had recurrent low-grade intermediate risk disease. So these are the patients we talked about. The big category of intermediate risk has larger tumors, multifocal tumors, and recurrent tumors. They really focused in Envision on those patients that were recurrent. They put 240 patients on that study, and it closed. And the 3-month data is available. So the same criteria, once a week for 6 weeks, patients got treatments. And then we looked back in their bladder in all patients. There was no TURBT arm. Every patient got the study drug. All 240 patients got the study drug. When we look back in at 3 months, and this data was presented at the SUO a couple of months ago, 79% of these patients, their bladders were clear and they were disease-free. So these patients, in my experience, are the ones that are really looking for this treatment. They keep recurring. They keep going back to the operating room. What we're doing right now doesn't seem to work for them. It's so frustrating for those patients when I tell them, when I look in with the cystoscope, I'm sorry, we have another tumor again, or I watched you once, we've got 2 more since the last time I checked, we got to go back to the operating room. Recurrent patients want something different. They're recurring with what we're doing anyway. And for these patients, at least the early results at 3 months, and that's all that's available, the study is still ongoing, the complete response rate was 79%. Almost 4 out of 5 patients were clear with a pre-existing tumor just following gel installation. So again, I think the 12-month durability data has to come. That's really important for drugs when we talk about this. How long is this going to last? But given the very favorable durability data for Atlas, I'm really excited to see what the 12-month durability data will be for Envision. And likely for the company, that will be the registration study, meaning that will be the one they put in for FDA approval. Because there are patients who ask me about when the drug's going to be available. There are providers who ask me when the drug's going to be available. But again, that 12-month durability data is not available. Patients are still in follow-up for the study. But I think the 3-month data is really, really important. So the study was stopped early. That was intentional. And the follow-up study so far, I think, is extremely promising in a cohort of patients where I think the drug is most valuable. The second limitation is the one I kind of alluded to earlier, but I want to talk to you about a little more detail because I think it's really important. And this is probably the primary limitation, criticism, objection to Atlas. And the limitation here is that when we do a TURBT, we have guidelines that tell us that after you do the TURBT within 24 hours, you should put in a washing of chemotherapy in the bladder for an hour or two. And that's based on a study called SWOG S0337. And that study looked at saline or salt water going in the bladder after someone did a TURBT and intravesical chemotherapy with a medicine called gemcitabine. And so that study said, hey, in the end, it looked like overall there's a value for these patients to have that be the case. And I would tell you, almost all the criticisms or all the editorial comments about the study say that, hey, your patients didn't get this chemotherapy. And because you didn't do that, you may have biased the group in favor of the study arm because you didn't give the TURBT arm the benefit of that. And I think that's a fair comment. We don't know what the contribution may have been if we had allowed intravesical chemotherapy to be given in the TURBT arm. But I do want to talk about why that was the case. So the first is that in general, when we look at estimates, even though the guidelines tell us, hey, we should be doing this, less than 1 in 5 patients by many studies receive this type of chemotherapy after resection. So the reality is the control arm, where there was not chemotherapy given, actually more accurately reflects what most patients who have low-grade intermediate risk disease actually get in the United States. So it's actually reflective of true practice patterns, not so much guidelines. The second is that this study, the SWOG study, which is a really important study, the authors went back and took a look, something called a post hoc analysis. And these are the authors of the primary study. They went back because the study group had this mix of patients. It had some what we call low-risk patients, right? So these are not patients that were in our category. They had a few high-risk patients that had high-grade disease. And they went back and looked and said, well, we've got this sort of heterogeneous mix of patients. In the end, we kind of found a benefit. But I wonder if there's a benefit more in any one of these particular groups. They kind of broke it down. They broke it down by, do you have more than one tumor or not? Do you have recurrences or not? Do you have a certain age or not? And what they really found was that the benefit was primarily seen in patients who had small tumors and solitary tumors. Small solitary tumors in our risk categorization are low risk, low-grade non-muscle invasive bladder cancer. That was actually a very large proportion of the SWOG study, but none of those low-risk patients are actually eligible in our study group, right? This study group is populated by a more aggressive behavior type. These are intermediate risk patients only in the Atlas study, whereas many patients in the SWOG study were low risk. The other thing is that 2/3 of our patients in the Atlas study cohort had multiple tumors. So we talked about those 3 risk factors: big tumors, right? SWOG didn't show benefit there. Multifocal tumors, and tumors that recur. In multifocal tumors, remember, 2/3 of the patients in this study had multiple tumors. The SWOG study looked specifically at patients with multiple tumors and found no benefit for chemotherapy in that patient population. Okay, so again, probably wouldn't have made a difference, hard to estimate how much, but again, that patient population for SWOG, when looking specifically at multiple tumors, did not find a benefit. That was the majority of the Atlas patients. And the final thing is we had this population of recurrent patients, right? They keep coming back, maybe the most important part of the whole population. That was 30% of our study population were recurrent patients. The SWOG study excluded these recurrent patients. It did not allow them to be in the study. And so highly recurrent patients were not part of SWOG. They're a really important part of our cohort. They're the entire part of the ENVISION cohort. So again, I do think that chemotherapy after TURBT matters, but it matters in small and solitary tumors. That's not the study group that was part of this study. And so again, I think while we may not be completely estimating the value in this population, the truth is most of our data either doesn't apply to the study population, or if it's applying to it like multiple tumors, it never showed a benefit. So those are kind of the 2 big limitations. We didn't finish the complete study, but we did go on to a second study that's really important, and I think so far showing very good results. And the second is this chemotherapy result, which I think is a little bit of apples and oranges when we start looking more deeply into the studies.
So bottom line, from the patient perspective, what does this all mean to the patient? You know, side effects, quality of life. In other words, what is the interpretation of this work for patient care?
Yeah, I'll tell you, it's been a really interesting process. So today, as I was getting ready in the locker room, I was thinking about my operative day, and I had 2 patients today who have low-grade intermediate risk non-muscle invasive bladder cancer. So one patient's on study, they're in follow-up on ENVISION. And I was thinking that when I was trying to sign patients up for clinical trials, and I do that for all of our clinical trials in our group, when you talk to patients about randomizing and doing a clinical trial where you might go on a surgery or you might go on a non-surgical treatment, that's actually a very difficult patient population for us to enroll. It's sort of hard for a patient to say, listen, you're going to flip a coin and you're going to tell me if I'm having an operation or I'm not having an operation. That's tough, I think, for people to kind of swallow. It's taking away some of the really important decision making that you think, we want patients to be able to make. But I'll tell you, in this study, patients were so enthusiastic about getting on trial. Remember, in Atlas, about half of the patients had prior TURBTs. They knew what that experience was like. And I can tell you, those patients wanted to be on study. They wanted to know when we were enrolling. They were disappointed when the study closed. They were excited when we reopened Envision. Patients want an alternative to TURBT. Most patients are not going to come through and say TURBT was a really wonderful experience and I can't wait to do it again. It's just not that type of treatment. So many of these patients know what they're getting. And again, in patients who have TURBT, we know that UGN 102, based on this study, shows a higher probability of being a complete responder, albeit close. It looks like for maybe highly recurrent patients, much better. And then it shows a durable response. And the safety profile is really excellent. So to me, patients who are seeing this are asking me about this because Atlas is now out there. The data is out there about this. So I've had patients ask me when the drug's going to be available, and I've had providers ask me when the drug's going to be available. For providers, I think it's a pretty easy concept to think about patients where TURBT just doesn't work that well for us, right? So we have some patients who just have a ton of low-grade disease in the bladder, and we're trying to go in and do our best to scrape it away, but it's just so difficult to do because really the bladder is almost like just completely filled with these tumors, and we're worried about putting a hole in the bladder, perforating the bladder, leading to bleeding. And so these patients, we know TURBT is not great for that. A non-surgical option, really appealing. Patients who recur, it's so frustrating and disappointing to see a patient who's doing all the right things, and then you look back in their bladder, and every time you look, or every other time you look, there's another tumor and their face drops. For many of those patients, I just tell them, listen, let's just watch it. It's only one. Let's wait till there's 2 or 3 or 4. But they're still going, I know I've got a tumor in my bladder, and yeah, I'll wait, but I'll do it in 3 months or I'll remove it. So those patients that keep recurring, we need something different. Providers want something different. And this gives us a completely alternative way of approaching highly recurrent tumors. And then the final group are the ones we've talked about already. These elderly, frail, older patients, they're on blood thinners. I don't want to take these patients to the operating room. I worry about them in the operating room. They're primary care doctors, they're cardiologists. They're worried about them. Dr. Prasad, start their blood thinner back as soon as he can, right? And so from provider perspective, I think there's a real need for some alternatives that are there. And then obviously for patients, you don't have to see your doctor for clearances. You don't have to see your cardiologist to hold your blood thinner. You don't have to go on shots of Lovenox to bridge between starting and stopping. You don't start for a bit, then bleed, then come off your blood thinner again and kind of go back and forth. You're not in the ER with a catheter that you need or a catheter that gets clogged. And then you don't have to have anesthesia. So the patient perspective, the appeal of non-surgical chemoablation, I think is intuitive. And I hope the drug is approved. And if it is approved, I think a lot of this will be driven by patients. I think patients are going to hear about this option. I think they're going to come to urologists and they're going to ask for it. I've heard this phrase, paradigm shifting, right? And paradigm shifting is the idea that you're changing the way in which you practice medicine. And I don't know if this study is the beginning of something that's paradigm shifting, but it's so exciting to be part of something that actually completely changed the way in which we treat one of the most common diseases in the United States from a cancer perspective. And so if this is the beginning of a shift where we're offering an effective, maybe equivalent, maybe even superior option to many patients that keeps them out of the operating room, I think this is potentially the beginning of what may be just a complete paradigm shift in the management of non-muscle invasive bladder cancer. And so again, I welcome your perspective, Tom, as a patient. I know we've talked about the study, we've talked about some limitations, which I think are important. We've kind of talked about it from our perspective and what I hear from patients, but let me know kind of what you think about when you hear about Atlas for the first time. I know you're not a bladder cancer patient, but you're a prostate cancer patient and you're a cancer survivor. And I think you carry with you a very unique perspective about the way in which these types of treatments affect you. And again, the audience, I really welcome you guys, if there's questions in the chat, to please ask about them. I think this type of dialogue is really helpful for us to understand some of these new and novel and exciting treatments that are coming to urology. So, Tom, but let me know. I'd love to hear your thoughts.
Well, I think this it's great. I mean, you've really educated me this evening and all. And again, I go back to the non-invasiveness and the being an older population and this and but still being able to go through this study is I think is a real uh, it's a real selling point, if you will, of it. But I would like to ask the audience if they have any specific questions.
Jennifer, I think you're managing that. I see a hand up.
I was looking
Yes.
for the mute button. Yes, please go ahead. Ashish Kote, please go
Yes,
ahead.
hi. Thank you, Dr. Prasad, for such a wonderful, talk and letting us know about like the novel therapy. Question I have is like, I mean, is there a dosage like you calculate for a patient, or it's like a prefix dose? Two, I mean, are there more cytopenias because of like the gel form you see, like especially like neutropenia, or and then three is like, are there maximum dosages you give patients, after the first 6 sessions?
Yeah, so it's a great question. So in all of the studies, there's only an induction phase, meaning the first 6 treatments. There's not a maintenance component to these studies. We obviously use maintenance in other uses of intravesical chemotherapy or in intravesical BCG. But for these studies, they were specifically looking at 6 initial treatments and then follow-up. You asked a bit about dosing. So there's a standard dose. It's 75 milligrams of mitomycin that's infused into 56 milliliters of this gel liquid. The bladder is drained initially, and then that volume is placed into every patient. So in many ways, it's very simple in that you're giving the base, you're not mixing it yourself. It comes pre-mixed, pre-administered, and you just deliver it through a catheter. So it's very, very simple to do. And then finally, you asked about really, I think, systemic absorption as a concern. I didn't go through the adverse events in detail. They're in the paper. But the beauty of the bladder is that it's an organ that's designed to hold toxic chemicals, right? The urine is filled with all the things that we want to get rid of. And so the bladder is really quite good at not absorbing these types of things. So in general, in terms of the anemias and other types of systemic absorption of chemotherapy type agents, that was not seen on this study. In fact, even when we do it in the upper tract, we put it up into the kidney with the product I alluded to earlier, UGN-101, the first formulation called JELMYTO, now FDA approved, those same types of cytopenias, anemias, and evidence of systemic absorption and bone marrow suppression were not seen in the upper tract either. So again, luckily for us, the urinary system is pretty resilient about reabsorption, and that really protects us and allows us to put these sorts of chemicals into the bladder. But good questions.
Thank you.
Any other questions?
Hi, this is Will Rapelson. Dr. Prasad, thank you for the presentation. I think, this seems to be like a renaissance for intravesical therapies and therapies of non-muscle invasive disease. I think that, even though, we have had some advances with IV systemic therapy like pembrolizumab, I think the durability of those responses are far below what we're hoping. And so I think with the advent of, of this therapy and also others like TAR-200 from the Sunrise study, I think we're seeing a kind of renaissance in, non-muscle invasive disease and less invasive therapies. And I agree with you, the benefit of avoiding, TURBT, OR, because it's such a, resource utilization problem, booking OR time. Sometimes patients have to wait several weeks to get, on the schedule. And in that period of time, the disease can progress. And some of these tumors can be large. They can be, 3 centimeters. And, a TUR may not be able to resect all of it, or if it does, you may be, creating some field cancerization effects by, taking it in a piecemeal fashion. So I think this is a great advance for our patients with non-muscle invasive disease. So sort of more of a comment than a question, but thank you.
And I think, you sort of picked up one of the things I think is really unique about these types of chemoablative therapies, right? So when we do resection, we can see the ambient tumor cells as we're scraping them with a resectoscope. we can see the dislodgement of tumor. And while we're trying to wash out all the tumor cells, there's fibrinous material in the urine. You can kind of see it floating here and there. And I think it's one of the reasons why we use adjuvant gemcitabine is simply to sort of give us additional time to drain out all those little bits of tumor possible redeposition. And so this approach is sort of different, right? It's sort of ablating the tumor, but not chopping it up. And I think that that may also be one of the advantages in terms of the durability data that was seen in theory, is that a way in which the cancer tumor is killed is actually in sort of a controlled fashion, where that sort of ambient spread that a resectoscope may cause isn't caused by topical chemoablation. And that also may be one of the reasons why we're seeing less recurrences and a more durable response with chemoablation. Thanks for that comment.
Sandeep?
Hey, Dr. Sapel, how are you? This is one of my senior
Good. So
partners, just retired.
were there patients with CIS in the study?
No, so this was
So they all had to have random biopsies to make sure they didn't have CIS, I guess,
Yeah,
right?
so these are all patients with documented biopsy-proven low-grade disease only and had negative cytologies. So these are all patients that were previously either, again, for recurrent patients had a prior diagnosis, and for patients who were de novo into the study had to have a biopsy of a portion of the tumor or one of multiple tumors to demonstrate low-grade disease. So, and that's the same way in which the SWOG study kind of had their same criteria were utilized. And so here, you know, again, you're leaving the tumor in situ, but confirming only the presence of low-grade disease. So these patients are only low-grade, but intermediate risk, non-muscle invasive bladder cancer patients. No CIS, no high-grade. Although, again, those are the types of populations where I think these types of treatments are likely to be investigated next if they're not already being investigated.
So do you see an algorithm change wherein you might diagnose a small low-grade papillary lesion in the office and put this medication in then without any biopsy?
So, you know, I would tell you, David, I know you have obviously a tremendous experience. I know that firsthand. I would tell you that in general, as urologists, we're pretty good, not perfect, but pretty good at visually assessing the grade and stage of papillary tumors, right? That a tumor has a low grade appearance. Occasionally we'll find it's a high grade, but still TA tumor. But I would tell you in general, we're pretty good at it. In my experience, I still think you need an initial biopsy to confirm that it's not high grade, especially for a product that's indicated only in the low grade space. But I think if you've done a biopsy and it's low grade, the crossover for an individual patient to go from low grade to high grade, it's low, right? It's in the single digits in general to go from low grade to high grade. It happens, but it's uncommon. So for a patient where I have already proven they have low grade disease and then they recur, or if I think it's a very large tumor, I may go and just do a biopsy and say, listen, it's low grade here in the most important part. I think it's reasonable to try. Again, you're going to go back 3 months later and check anyway. So it's uncommon unless you're missing a muscle invasive bladder cancer, which obviously shouldn't be where you ever use a product like this. If you have that suspicion, you should do a proper TURBT. But for most patients, in 3 months with a repeat evaluation cystoscopically and then a resection if you need it, I doubt you're burning any significant bridges. And again, if you're looking at the majority of patients, whether it's Atlas or almost 80% of patients, if you look at Envision, where patients are complete responders, many of these patients, if not, you know, many of them are going to do extremely well at 3 months. And for those that didn't, you can then go ahead and do the TURBT you meant to do anyway. So again, when we talk about paradigm shifting, I think the question will be, are you going to do that first and just mop up whatever's left with a TURBT, knowing that for most patients, they'll never have to do that. They can just get a system and be clear in the office and then see them the next time around, right? So I think that'll be kind of how guidelines and expert panels begin to look at these products once they're FDA approved. In my opinion, you still should do a biopsy and confirm you have low-grade disease. But I will tell you, as you know, urologists are pretty good at determining that. We're not perfect. And so I think a biopsy is important. But your gestalt is, you know, a sessile tumor. It's not going to be low-grade, non-invasive. That single papillary tumor on the stalk, we all kind of know what that one looks like. In a patient who's had prior low-grade disease, I think you can be pretty confident that's going to be low-grade as well.
And I would imagine that if the patient has CIS, they should take care of it when you're treating that low-grade papillary lesion.
Yeah, so I'm a believer in resection of CIS. I think that it's a tumor that you just don't treat with topical. So I know there's some people who biopsy CIS, it could BCG. I don't manage CIS that way. I resect it. And I think if a patient has a history of high-grade disease, they're immediately a high-risk patient forever. And for me, that would not be a patient I would use this in. I mean, maybe 5 years later, they're disease-free and they show up with a single papillary lesion. You know, we would think about that potentially. But I think once a patient is high risk because of their CIS, that's their NCCN risk category, that's their category forever. So again, I would probably stay away from those types of things, but we all know that CIS and a papillary tumor are different biologies, they're different diseases, and they can occur concomitantly. But again, I probably wouldn't think about these types of products for low-grade disease in patients where I know they have a history of CIS.
Excellent presentation, Dr. Prasad.
Thanks, David.
Well, we really do appreciate the questions and the comments, and I would just like to ask Dr. Prasad if you have any final thoughts.
Well, again, I'll leave it to Jennifer to kind of to lead us forward, but I think, Tom, we're going to be seeing each other in a few weeks, I think sometime next month, to be able to talk a bit more about this study, because I think, again, it has the potential to be practice changing. And we're going to talk to a couple of the authors of some of the editorial comments that I alluded to, and really trying to have in the Zoom primary discussion along with the audience, kind of having another set of conversations about where this may fit in with patients. And I think the really exciting part of that conversation is we're going to bring in a couple of patients who've had the product and talking to patients who've not been on study and have undergone 2 RBTs and having their firsthand experience. And then actually one of my wonderful patients who was a study patient has agreed to join us. I'm so excited to have him. He's probably one of the best human beings you'll ever meet, and I'm excited that he'll join us. And he'll talk to you a bit about the study drug. And Tom, I'd encourage you, I'm going to step back and I'm going to let you talk to him as a patient and talk to him about his experience with the drug. Whatever he wants to talk to you about is great. But I think that's going to be a really robust discussion between urologists who have, potentially differing opinions on this study, as well as patients who have either not been part of it and have been part of it and gaining their perspective. And I think that's really I love that the AUA is doing these types of programs. I think this is so much more impactful than a series of just physicians talking amongst themselves. So Jennifer, I wanted to thank you for inviting me today. I'm excited to join you with one of my patients in about a month. Tom, I really enjoyed speaking with you and meeting you tonight. And I look forward to talking to you in about a month too.
Well, again, I appreciate it. We appreciate it. It's very educational, and there really is as you said, a paradigm shift here potentially. And I look forward to learning more. So.
And thank you both for your time. And yes, Dr. Prasad is absolutely correct. We look forward to welcoming one of his patients, another patient who is a bladder cancer patient, but was not part of this trial, and some authors of editorial comments directly related to that research. But again, thank you both for your insights and for having such a great conversation. Truly appreciate it. I don't see any more questions or hands raised from the audience, so I think we're all set. We appreciate that everyone took time from their day to join us for this important conversation.
Thank you, Jennifer.
And we thank you for taking the time to give the presentation when you should be home with the family eating dinner.
All right, everybody get to it. Thanks so much. Have a good night.
Thanks, everyone.
Thank you, everyone.
Thank you.